Please.
Professor Cassidy, Professor Bucks, ladies and gentlemen, my great pleasure on behalf of Professor Brachman and the steering committee and my co-investigators at Castle AF to share with you our results of our trial, catheter ablation versus standard conventional treatment in patients with left ventricular dysfunction and atrial fibrillation. So my disclosures. As you all know, atrial fibrillation and heart failure is very well intertwined. In fact, more than 30% of patients with heart failure will suffer or are suffering from atrial fibrillation. Catheter ablation over the last 20 years has not only been shown to be effective and useful in patients with normal hearts, but also in patients with heart failure. The rationale and objective of Castle OIF was to study the effectiveness of catheter ablation of atrial fibrillation in patients with heart failure in improving hard primary endpoints of mortality and worsening or progressing of heart failure when compared to conventional standard treatment of these patients. The primary point of Castle, as listed here, was a composite of all-cause mortality and worsening heart failure admission, whatever comes first. Obviously, we looked at a lot of secondary endpoints listed here as well. To mention some, we looked at cardiovascular mortality, cardiovascular hospitalization, all-cause mortality, quality of life, AFib burden, VT and VF, and so on. Patients were included in Castle if they presented with symptomatic, paroxysmal, or persistent, including long-standing persistent atrial fibrillation. Patient had to fail at least one antiarrhythmic drug or be intolerant to one antiarrhythmic drug, or have to be unwilling to take the drug if they consented. EF have to be less or equal to 35%. Patient had to be in New York Heart Class 2 or higher. We included patients who already have an ICD or BIV-ICD implanted for primary or secondary prevention with the home monitoring capability from BIOTRONIK. Castle was an investigator-initiated industry sponsor that was sponsored by BIOTRONIK, prospective, multi-center, 31 sites, 9 countries, randomized, controlled. This slide showed you the flow chart from the beginning to the end. We screened 3,013 patients. We ended up consenting and randomizing 397 patients. After a run-in period of 5 weeks to optimize the heart failure treatment, we ended up having 179 patients in ablation group and 184 patients in the conventional arm group, which is followed for a mean of 37 months up to a maximum of 60 months or 5 years. So the first year, patients were followed every 3 months. After that, every year, and we looked at all these criteria mentioned here. We collected all this data. So we analyzed the data based on the modified intention to treat statistics from the baseline characteristic and after, so 179 patients, 184 patients. The patients in the conventional arm were treated based on the ACC, AHA, ESC 2006 guidelines for treatment of AFib and heart failure. We recommended the patient to be in sinus rhythm, but we did not mandate it. If the investigator elected to have the patient in the rate control strategy, then we recommended the baseline or a resting heart rate of 60 to 80, and then a heart rate of 90 to 115 after moderate exercise. All patients were anticoagulated in both arms, not only in this arm, and then target INR of 2 to 3. If the patient was included in an ablation arm or the catheter ablation arm, pulmonary vein isolation was mandated. In fact, we have 98.4% of patients had successful pulmonary vein isolation after an initial procedure. Additional lesions targeting additional lines or different physiology like complex fractionated electrograms or rotors and so on, or low voltage area of fibrosis were left at the discretion of the operator. We allowed repeat ablation in Castle after a blanket period of 3 months. The mean age of the population is shown here as 64 years old. The majority of patients were neoclass class 2, as you see here, around 60% of patients. Majority of the patients presented with persistent AFib, but we still have 30% of our population, around 35, were in paroxysmal AFib. Third of the persistent AFib patients, around third, were long-standing persistent. And the majority of patients had a dual chamber ICD. Less than a third had the bi-V ICD. This slide shows you that more than 90% of the patients at baseline, when the treatment was initiated, were treated and optimized and treated with an appropriate heart failure treatment, including ACE inhibitors, ARBs, beta blocker, diuretics, including spironolactone. And more than 90% of patients were anticoagulated, as you see in this slide, in both groups. Only 32 versus 30% of patients took antiarrhythmic drugs at the beginning of the trial, and the majority, or the number one drug used, obviously, in this patient population was amiodarone. In the conventional arm, when the most initiated treatment, when the operator have to choose, or when the investigator have to choose between rate control and rhythm control, you can tell the majority chose the rate control approach to treat the patient. More than 60% of the patients were treated with rate control approach and not the rhythm control approach. And this doesn't surprise us, especially after the publication of AF-CHF trial a while ago. So there was no difference anyway. So people obviously chose the rate control in that case. Obviously, from the devices in our patients, that was allow us the luxury to look at AFib over the duration of 5 years in every single patient, and to look at the AFib burden in both groups. And it's not surprising that ablation led to a significant reduction in AFib burden in our patient population. In fact, 63% of the patients in the ablation arm, were in sinus rhythm at 5 years at the end of the study. We also looked at ejection fraction changes over time, and as you can tell, at 12 months, 36 months, and 60 months follow-up, catheter ablation led to significant improvement in ejection fraction compared to conventional treatment. In fact, at the end of the study, at 5 years, 8% increase in the ablation arm versus none in the conventional arm. I listed here some of the serious adverse events that brought with me, and then acutely we saw 3 patients that suffered pericardial effusion in ablation arm, and 3 persons had severe bleeding that required blood transfusion or treatment. Over the period of study, we detected 1 asymptomatic accidental on CT scan pulmonary vein stenosis in the ablation arm, but the incidence of stroke and TIA was almost double in the conventional arm over the period of study, although the anticoagulation regimen was similar in both arms, 7 versus 12 patients. Ladies and gentlemen, this is the primary finding in CASTLE. After 8.5 years of study duration, catheter ablation of AFib led to significant improvement of the primary composite endpoint of all-cause mortality and worsening heart failure admission, with a risk reduction of 38%, highly significant. When you looked at the all-cause mortality, catheter ablation led to a risk reduction of 47%, also significant. The curves are splitting later on in the study, but also significant. When you looked at the worsening heart failure admissions, catheter ablation led to a highly significant 44% risk reduction. And then I have to highlight here that the curves split early on in the study. After 6 months, they start splitting for the worsening heart failure admissions. Cardiovascular mortality, which seems to be main driver for mortality, also was significant. So catheter ablation led to 51% reduction in mortality of cardiovascular mortality. The same for cardiovascular hospitalization. Catheter ablation was significant in reducing cardiovascular hospitalization with 28% reduction. I brought with me some selected subgroups from the forest plot, and you can see almost every single box on the size of ablation except a patient with a very low ejection fraction. Barbara Giron, allow me to conclude the finding from our study, CASL-AF. Catheter ablation for atrial fibrillation in patients with heart failure led to an improvement of all-cause mortality and led to fewer admissions for worsening heart failure when compared to the conventional adaptive treatment today. The driver for this seems to be the cardiovascular mortality and cardiovascular hospitalization, which also improved in the catheter ablation arm. A study like this will not happen without a group of people. I want to thank our steering committee who handled us all over the 9 years, and the resilient co-investigators who never gave up on us to make the study a success. The DSMB and the Adverse Emitting Committee, but last but not least, BIOTRONIK, who stuck with us over the years, and their unknown soldiers and the team of Jochen Prof in Berlin. Thank you so much.
And then may I please invite Dr. Karin Blomstrom-Lundquist to be the discussant on this very nice study.
Professor Bax, Professor Catheter